Today we are going to discuss about Cipesta, which contains ciprofloxacin hydrochloride. Description: Ciprofloxacin hydrochloride tablets is a synthetic broad-spectrum antimicrobial agent for oral administration. Chemically, ciprofloxacin hydrochloride, a fluoroquinolone, is the monohydrochloride monohydrate salt of 1-cyclopropyl-6-fluoro-1, 4-dihydro-4-oxo-7-1-piperazine-3 quinylene carboxylic acid. The molecular formula is C17H18FN3O3.HClH2O. Composition: each film-coated tablet contains active ingredient ciprofloxacin USP equivalent to ciprofloxacin 250 mg. Each film-coated tablet contains active ingredient ciprofloxacin HCl USP equivalent to ciprofloxacin 500 mg. Clinical pharmacology. Mechanism of action: ciprofloxacin is a synthetic 4-quinolone derivative, with bactericidal activity. It acts via inhibition of bacterial DNA gyrase, topoisomerase, which is essential in the reproduction of bacterial DNA, ultimately resulting in interference with DNA function. Ciprofloxacin is highly active against a wide range of gram-positive and gram-negative organisms and has shown activity against some anaerobes. Microbiology: ciprofloxacin has in vitro activity against a wide range of gram-negative and gram-positive microorganisms. Aerobic gram-positive microorganisms: Enterococcus faecalis, many strains are only moderately susceptible, Staphylococcus aureus, methicillin-susceptible strains only, Staphylococcus epidermidis, Staphylococcus saprophyticus, Streptococcus pneumoniae, Streptococcus pyogenes. Aerobic gram-negative microorganisms: Campylobacter jejuni, Citrobacter diversus, Citrobacter freundii, Enterobacter cloacae, Escherichia coli, Haemophilus influenza, Haemophilus parainfluenza, Klebsiella pneumonia, Moraxilla catarrhalis, Morganella morgani, Neisseria gonorrhoeae, Proteus mirabilis, Proteus vulgaris, Providencia rettgeri, Providencia stuarti, Pseudomonas aeruginosa, Salmonella typhi, Serratia marxans, Shigella boydii, Shigella dysenteriae, Shigella flexneri, Shigella sonii. Ciprofloxacin has been shown to be active against Bacillus anthracis both in vitro and by use of serum levels as surrogate marker. Pharmacokinetics. Absorption: ciprofloxacin tablet is rapidly and well absorbed from gastrointestinal tract after oral administration. The absolute bioavailability is approximately 70% with no substantial loss by first pass metabolism. Maximum serum concentrations are attained 1 to 2 hours after oral dosing. Mean concentrations 12 hours after dosing with 250 mg, 500 mg, or 750 mg are 0.1, 0.2, and 0.4 microgram per milliliter respectively. Serum concentrations increase proportionally with doses up to 1000 mg. Distribution: plasma protein binding ranges from 20 to 40%. Ciprofloxacin is widely distributed in the body and tissue penetration is generally good. It appears in the cerebral spinal fluid, but concentrations are only about 10% of those in plasma when the meninges are not inflamed. Ciprofloxacin crosses the placenta and is also distributed in breast milk. High concentrations are achieved in bile. Metabolism: 4 metabolites have been identified in human urine which together account for approximately 15% of an oral dose. The metabolites have antimicrobial activity, but are less active than unchanged ciprofloxacin. Ciprofloxacin is an inhibitor of human cytochrome P4501A2 mediated metabolism. Co-administration of ciprofloxacin with other drugs primarily metabolized by cytochrome results in increased plasma concentrations of these drugs. Excretion: the serum elimination half-life in subjects with normal renal function is approximately 4 hours. Approximately 40 to 50% of an orally administered dose is excreted in the urine as unchanged drug. The urinary excretion of ciprofloxacin is virtually complete within 24 hours after dosing. The renal clearance of ciprofloxacin, which is approximately 300 ml per minute, exceeds the normal glomerular filtration rate of 120 ml per minute. Thus, active tubular secretion would seem to play a significant role in its elimination. Although bile concentrations of ciprofloxacin are several-fold higher than serum concentrations after oral dosing, only a small amount of the dose administered is recovered from the bile as unchanged drug. An additional 1 to 2% of the dose is recovered from bile in the form of metabolites. Approximately 20 to 35% of an oral dose is recovered from the feces within 5 days after dosing. This may arise from either biliary clearance or transintestinal elimination. Only small amounts of ciprofloxacin are removed by hemodialysis or peritoneal dialysis. Special population: geriatric patient. Oral plasma concentrations of ciprofloxacin are higher in elderly, greater 65 years, as compared to young adults. Although the Cmax is increased 16 to 40%, the increase in mean area under curve is approximately 30%, and can be at least partially attributed to decreased renal clearance in the elderly. Elimination half-life is only slightly prolonged in the elderly. These differences are not considered clinically significant. Renal insufficiency. In patients with reduced renal function, the half-life of ciprofloxacin is slightly prolonged. Dosage adjustments may be required. Hepatic insufficiency. In patients with stable chronic liver cirrhosis, no significant changes in ciprofloxacin pharmacokinetics have been observed. Therapeutic indications. Adults. Lower respiratory tract infections due to gram-negative bacteria, exacerbations of chronic obstructive pulmonary disease, bronchopulmonary infections in cystic fibrosis or in bronchiectasis, pneumonia. Chronic suppurative otitis media. Acute exacerbation of chronic sinusitis, especially if these are caused by gram-negative bacteria. Urinary tract infections. Genital tract infections, gonococcal urethritis and cervicitis due to susceptible Neisseria gonorrhoeae, epididymo-orchitis including cases due to susceptible Neisseria gonorrhoeae, pelvic inflammatory disease including cases due to susceptible Neisseria gonorrhoeae, infections of the gastrointestinal tract, e.g. traveler's diarrhea. Intra-abdominal infections. Infections of the skin and soft tissue caused by gram-negative bacteria. Malignant external otitis. Infections of the bones and joints. Prophylaxis of invasive infections due to Neisseria meningitidis. Inhalation anthrax, post-exposure prophylaxis and curative treatment. Typhoid fever caused by Salmonella typhi. Ciprofloxacin may be used in the management of neutropenic patients with fever that is suspected to be due to a bacterial infection. Children and adolescents. Bronchopulmonary infections in cystic fibrosis caused by Pseudomonas aeruginosa. Complicated urinary tract infections and pyelonephritis. Inhalation anthrax, post-exposure prophylaxis and curative treatment. Ciprofloxacin may also be used to treat severe infections in children and adolescents when this is considered to be necessary. Treatment should be initiated only by physicians who are experienced in the treatment of cystic fibrosis and/or severe infections in children and adolescents. Dosage and administration. Ciprofloxacin tablets can be taken independent of meal times. Ciprofloxacin should be administered at least 2 hours before or 6 hours after magnesium/aluminum antacids, or sucralfate, didenosine chewable/buffered tablets or pediatric powder for oral solution, other highly buffered drugs, or other products containing calcium, iron, or zinc. Adults. Ciprofloxacin tablets should be administered orally to adults as described in the dosage guidelines table. The determination of dosage for any particular patient must take into consideration the severity and nature of the infection, the susceptibility of the causative organism, the integrity of the patient's host defense mechanisms, and the status of renal function and hepatic function. The dosage range for adults is 100 to 750 mg twice daily. The duration of treatment depends upon the severity of infection. The usual duration is 7 to 14 days, however for severe and complicated infections more prolonged therapy may be required. Dosing in children with impaired renal and/or hepatitis C function has not been studied. Contraindications. Ciprofloxacin is contraindicated in patients with a history of hypersensitivity to ciprofloxacin, any member of the quinolone class of antimicrobial agents or any of the product components. Concomitant administration with tizanidine is contraindicated. Adverse reactions. Common: nausea, diarrhea. Uncommon mycotic superinfections, eosinophilia, anorexia, psychomotor hyperactivity/agitation, headache, dizziness, sleep disorders, taste disorders, vomiting, gastrointestinal and abdominal pains, dyspepsia, flatulence, increase in transaminases, increased bilirubin, rash, pruritus, urticaria, musculoskeletal pain, e.g. extremity pain, back pain, chest pain, arthralgia, renal impairment, asthenia, fever, increase in blood alkaline phosphatase. Rare. Antibiotic-associated colitis, very rarely with possible fatal outcome, leukopenia, anemia, neutropenia, leukocytosis, thrombocytopenia, thrombocythemia, allergic reaction, allergic edema/angioedema, hyperglycemia, confusion and disorientation, anxiety reaction, abnormal dreams, depression, potentially culminating in suicidal ideation/thoughts or suicide attempts and completed suicide, hallucinations, paresthesia, hypoesthesia, tremor, seizures, including status epilepticus. Vertigo, visual disturbances, e.g. diplopia, tinnitus, hearing loss/hearing impaired, tachycardia, vasodilatation, hypotension, syncope, dyspnoea, including asthmatic condition, hepatic impairment, cholestatic icterus, hepatitis, photosensitivity reactions, myalgia, arthritis, increased muscle tone and cramping, renal failure, hematuria, crystalluria, tubuloid interstitial nephritis, edema, sweating, hyperhidrosis, increased amylase. Very rare. Hemolytic anemia, agranulocytosis, pancytopenia, life-threatening, bone marrow depression, life-threatening, anaphylactic reaction, anaphylactic shock, life-threatening, serum sickness-like reaction, psychotic reactions, potentially culminating in suicidal ideation/thoughts or suicide attempts and completed suicide, migraine, disturbed coordination, gait disturbance, olfactory nerve disorders, intracranial hypertension, visual color distortions, vasculitis, pancreatitis, liver necrosis. Very rarely progressing to life-threatening hepatic failure, petechiae, erythema multiforme, erythema nodosum Stevens-Johnson syndrome, potentially life-threatening, toxic epidermal necrolysis, potentially life-threatening, muscular weakness, tendinitis, tendon rupture, predominantly Achilles tendon, exacerbation of symptoms of myasthenia gravis. Not known peripheral neuropathy, ventricular arrhythmia and torsades de pointes, reported predominantly in patients with risk factors for QT prolongation, ECG QT prolonged, acute generalized exanthematous pustulosis, AGEP, international normaliste ratio increased, in patients treated with vitamin K antagonists. Precautions. Hypersensitivity reactions, hypersensitivity and allergic reactions, including anaphylaxis and anaphylactoid reactions, may occur following a single dose and may be life-threatening. If such reaction occurs, ciprofloxacin should be discontinued and an adequate medical treatment is required. Cns disorders. As with all quinolones, ciprofloxacin should be used with caution in patients with known or suspected CNS disorders that may predispose to seizures or lower the seizure threshold, e.g. severe cerebral arteriosclerosis, epilepsy, or in the presence of other risk factors that may predispose to seizures or lower the seizure threshold, e.g. certain drug therapy, renal dysfunction. Ciprofloxacin should be discontinued in patients experiencing symptoms of neuropathy, including pain, burning, tingling, numbness, and or weakness in order to prevent the development of an irreversible condition. Crystalluria related to the use of ciprofloxacin has been reported. Patients receiving ciprofloxacin should be well hydrated and excessive alkalinity of the urine should be avoided. Patients with a family history of actual defects in glucose 6-phosphate dehydrogenase activity are prone to hemolytic reactions with quinolones, and so ciprofloxacin should be used with caution in these patients. Musculoskeletal system. Ciprofloxacin should be discontinued if the patient experiences pain, inflammation, or rupture of a tendon. Patients should rest and refrain from exercise until the diagnosis of tendinitis or tendon rupture has been excluded. Tendon rupture can occur during or after therapy with quinolones, including ciprofloxacin. Fluoroquinolones may exacerbate muscle weakness in person with myasthenia gravis. Avoid in patients with known history of myasthenia gravis. There is a risk of pseudomembranous colitis possibly leading to a fatal outcome. It is important to consider this in patients suffering from severe, persistent diarrhea. If pseudomembranous colitis is suspected, treatment with ciprofloxacin should be stopped and appropriate treatment given. Drugs that inhibit peristalsis must not be given. Photosensitivity reactions. Ciprofloxacin has been shown to produce photosensitivity reactions. Patients taking ciprofloxacin should avoid direct exposure to excessive sunlight or UV light. Therapy should be discontinued if photosensitization, i.e., sunburn-like skin reactions, occur. Peripheral neuropathy. Ciprofloxacin should be discontinued if the patient experiences symptoms of neuropathy including pain, burning, tingling, numbness and or weakness, or is found to have deficits in light touch, pain, temperature, position sense, vibratory sensation, and or motor strength in order to prevent the development of an irreversible condition. Syphilis. Antimicrobial agents used in high dose for short periods of time to treat gonorrhea may mask or delay the symptoms of incubating syphilis. All patients with gonorrhea should have a serologic test for syphilis at the time of diagnosis. Patients treated with ciprofloxacin should have a follow-up serologic test for syphilis after 3 months. Cardiac disorders. Caution should be taken when using fluoroquinolones, including ciprofloxacin, in patients with known risk factor S for prolongation of the QT interval, such as, for example, congenital long QT syndrome. Concomitant use of drugs that are known to prolong the QT interval, e.g. class IA and 3 antiarrhythmics, tricyclic antidepressants, macrolides, antipsychotics. Uncorrected electrolyte imbalance, e.g. hypokaliemia, hypomagnesemia. Cardiac disease, e.g. heart failure, myocardial infarction, bradycardia. Elderly patients and women may be more sensitive to QTc prolonging medications. Therefore, caution should be taken when using fluoroquinolones, including ciprofloxacin, in these populations. Hepatobiliary system. Cases of hepatic necrosis and life-threatening hepatic failure have been reported with ciprofloxacin. In the event of any signs and symptoms of hepatic disease, such as anorexia, jaundice, dark urine, pruritus, or tender abdomen, treatment should be discontinued. Pregnancy. There are no adequate and well-controlled studies in pregnant women. Ciprofloxacin should not be used during pregnancy unless the potential benefit justifies the potential risk to both fetus and mother. Nursing mothers. Ciprofloxacin is excreted in human milk. Because of the potential for serious adverse reactions in infants nursing from mothers taking ciprofloxacin, a decision should be made whether to discontinue nursing or to discontinue the drug, taking into account the importance of the drug to the mother. Drug interactions. Cytochrome P450, CYP450. Ciprofloxacin inhibits cytochrome P1A2 and thus may cause increased serum concentration of concomitantly administered substances metabolized by this enzyme, example theophylline, clozapine, tacrin, ropinirole, tizanidine, duloxetine. Therefore, Patients taking these substances concomitantly with ciprofloxacin should be monitored closely for clinical signs of overdose, and determination of serum concentrations, especially of theophylline, may be necessary. Chelation complex formulation. Ciprofloxacin should be administered at least 2 hours before or 6 hours after multivalent cationic drugs and mineral supplements, example calcium, magnesium, aluminum, or iron, polymeric phosphate binders, example sevelamer, sucralfate, or antacids, and highly buffered drugs, example didenosine, as interference with absorption may occur. When appropriate, patients should be advised not to self-medicate with preparations containing these compounds during therapy with ciprofloxacin. This restriction does not apply to the class of H2 receptor blocker drugs. Theophylline. Serious and fatal reactions have been reported in patients receiving concurrent administration of ciprofloxacin and theophylline. If concomitant use cannot be avoided, serum levels of theophylline should be monitored and dosage adjustments made as appropriate. Other xanthine derivatives. Raised serum concentrations of caffeine or pentoxifylline, oxpentafyllin, were reported on concurrent administration of these xanthine derivatives. Phenytoin. Phenytoin levels may be altered when ciprofloxacin is used concomitantly. Glyburide/glibenclamide. The concomitant administration of ciprofloxacin with the sulfonylurea glyburide and glibenclamide has on rare occasions resulted in severe hypoglycemia. Warfarin. Quinolones, including ciprofloxacin, have been reported to enhance the effects of the oral anticoagulant warfarin or its derivatives. When these products are administered concomitantly, prothrombin time or other suitable coagulation tests should be closely monitored. Probenecid. Probenecid interferes with renal tubular secretion of ciprofloxacin and produces an increase in the level of ciprofloxacin in the serum. This should be considered if patients are receiving both drugs concomitantly. Methotrexate. Renal tubular transport of methotrexate may be inhibited by concomitant administration of ciprofloxacin, potentially leading to increased plasma levels of methotrexate. This might increase the risk of methotrexate-associated toxic reactions. Therefore, patients under methotrexate therapy should be carefully monitored when concomitant ciprofloxacin therapy is indicated. Metaclopramide. Metaclopramide significantly accelerates the absorption of oral ciprofloxacin, resulting in shorter time to reach maximum plasma concentrations. No significant effect was observed on the bioavailability of ciprofloxacin. NSAIDs. Nonsteroidal anti-inflammatory drugs, but not acetyl salicylic acid, in combination of very high doses of quinolones, have been shown to provoke convulsions. Food and dairy products. The concurrent administration of dairy products or mineral-fortified drinks alone, example milk, yogurt, calcium-fortified orange juice, and ciprofloxacin, should be avoided because absorption of ciprofloxacin may be reduced. Dietary calcium as part of a meal, however, does not significantly affect absorption. Omeprazole. Concomitant administration of ciprofloxacin and omeprazole results in a slight reduction of Cmax and area under curve of ciprofloxacin. Cyclosporin. A transient rise in the concentration of serum creatinine was observed when ciprofloxacin and cyclosporin were administered simultaneously. Therefore, it is necessary to monitor the serum creatinine concentrations in these patients frequently, twice a week. Sildenafil. Upon concomitant administration of an oral dose of 50 mg sildenafil with 500 mg ciprofloxacin, Cmax and area under curve of sildenafil were increased approximately twofold. Therefore, caution should be used prescribing ciprofloxacin concomitantly with sildenafil, taking into consideration the risks and the benefits. Overdosage. In the event of acute overdosage, reversible renal toxicity has been reported in some cases. The stomach should be emptied by inducing vomiting or by gastric lavage. The patient should be carefully observed and given supportive treatment, including monitoring of renal function, including urinary pH and acidify, if required, to prevent crystalluria, and administration of magnesium, aluminum, or calcium-containing antacids which can reduce the absorption of ciprofloxacin. Adequate hydration must be maintained. Only a small amount of ciprofloxacin, less than 10%, is removed from the body after hemodialysis or peritoneal dialysis. Storage. Store at 25 degrees Celsius, excursions permitted between 15 degrees Celsius, 30 degrees Celsius. Protect from sunlight and moisture. Thank you for watching. Please like and subscribe my channels. Thank you again.